Welcome. My name is Kimberly Dorris. I'm the Executive Director of the Graves' Disease and Thyroid Foundation. Tonight we'll be answering your questions about Graves' disease and thyroid eye disease, also called TED or TED. We had over 100 people register today for the event, and we've selected the most frequently occurring questions to cover tonight. And you can also use the Q&A feature to type your question directly in there, and we'll get to as many of those that we can in that format. If we don't get to your question tonight, reach out to the GDATF and we'll try to find an answer for you. This program is being recorded and it will be posted on our YouTube channel in the coming days, and no outside recording is permitted. I'm very grateful to our co-hosts at the AAES and to our moderators and panelists for making this program possible. A quick reminder that our panelists are happy to answer general questions, but they're not able to give medical advice. And with that, I will hand the program off to our moderators.
Good evening and welcome everyone. I am Dr. Iuliana Bobanga. I'm an endocrine surgeon at Matsu Surgical Associates in Wasilla, Alaska. And I'm joined tonight by my co-moderator, Dr. Alexander Chiu. We represent the Patient Advocacy Committee of the American Association of Endocrine Surgeons. We want to thank Kimberly, Dorris, and our partners at the Graves' Disease and Thyroid Foundation for hosting this webinar together with the AAES. We received a large number of questions from all of you, and reading through them, it was apparent that this was not a general audience asking for the basics of Graves' disease, but patients who have had a lot of experience, who've navigated confusing labs, consultations, different recommendations, and you guys really are past the basics. So we're going to skip those basic things and we're going to go straight to some of your questions, and we're going to have our expert panel try to answer those for you. So with that, I would like our panelists to just say hello and introduce themselves and tell us where they're from. Dr. Shin?
Hi, my name is Joyce Shin. I'm an endocrine surgeon at the Cleveland Clinic in Cleveland, Ohio.
Thank you. Dr. Mammen?
Hi, I'm Jennifer Mammen. I'm an endocrinologist at Johns Hopkins in Baltimore, Maryland.
Thank you. Dr. Douglas?
Hi, Ray Douglas. I'm an oculoplastic and orbit surgeon at Cedars-Sinai and also in Beverly Hills.
Thank you. Dr. Lindeman?
Hello, everyone. My name is Brenessa Lindeman. I am also an endocrine surgeon, and I'm at the University of Alabama at Birmingham in Birmingham, Alabama.
Great. And Dr. Chiu?
Hi, everyone. My name is Alex Chiu. I'm also an endocrine surgeon at the University of Wisconsin in Madison.
Great. Thank you. And just as Kimberly mentioned, we will be taking some live questions in the Q&A section. This session is being recorded and will be available both on the Graves' Disease and Thyroid Foundation website and on the AAES YouTube channel. So with that, we're going to go ahead and dive into those questions, and I will let Dr. Chiu get us started.
Sure. So this first question is going to be directed at Dr. Mammen, and it's about labs and testing. And there's a lot of questions regarding to what tests need to be done, TSH, T3, T4, free T3, and the role of antibodies. I was wondering if you could just talk a little bit about what patients should know and think about when they are getting lab work done.
Yeah, so really good question, because it can be very confusing, and the answer is that it depends sort of on what stage we're at in the disease process, which labs are the most helpful and the most influential. So the TSH is that sort of central monitoring lab that we use the most, because the TSH is the thyroid stimulating hormone. It comes from the pituitary. And if I know Dr. Bogan talked about we're not going to do the basics, but if you remember, right, the hypothalamus is above the pituitary and the thyroid is below. And so that the pituitary is really integrating signals both from above and below to give us that central read on how well all of the system is working. And so when I talk about this with patients, I use the analogy of a car. The pituitary is the driver of the car, and it's using TSH the way you use the pressure on your gas pedal to regulate how fast your car is going. Either got the brake on if you're hyperthyroid, or the pressure on the gas pedal if you're a little hypothyroid, to try and get things moving. But the system actually is relatively slow to regulate because the thyroid has a lot of thyroid hormone in reserve. And this is why the car analogy breaks down a little bit. And especially when we're initially trying to treat patients, and especially patients with Graves' disease, the thyroid can make a lot of extra thyroid hormone and release it at a very rapid rate. And when we initiate treatment, the pituitary takes a long time to believe that we've really got the thyroid under control and we've got those levels down, and the TSH doesn't change right away. And so we look directly at the thyroid hormones to understand how our therapy is responding in those first couple weeks or right after a dose change, to make sure that we're trying to hit that Goldilocks range and not overshoot or undershoot, but really try to control things in a good and rapid way. Then we're going to look at the thyroid hormone levels. And it is the case, especially like I was saying in Graves' disease, that because the thyroid in many people with Graves' disease is actually overproducing the most active form of thyroid hormone, the T3, we do need to look directly at the T3 to really understand in the acute phase what the hormone is doing. That can be challenging though, because the T3 assays are not our most reliable assays. T3 is a very short acting hormone. It's got a short half-life. The test characteristics of the T3 assays are the least reliable of all of the assays. And so as physicians, we don't like to use the T3 assay because it gives us a lot of variability time, and it's not very reproducible. You take the same assay one day, the next, whether somebody had their coffee in the morning or not, it's going to change how, what the T3 level is a little bit. So yes, we like to use the T3 in that short term, but we can't rely on it as, as a stable indicator with a pinpoint precision the way we do in that sort of more long-term, okay, are we do we really have the disease under control? Do we have the TSH in range? Is your body really happy? Is your brain really happy with where we've got things leveled out? So each of those hormones, because of the different length of time it takes, their role in the feedback, each of those hormones plays a different role at a different time course in how we monitor the disease.
Great. That's really helpful. Thank you. And I think one other side of labs that we always got a lot of questions about is with the thyroid antibody. And I also want to bring in Dr. Douglas with this and saying how you think about thyroid antibodies, and in particular, how this impacts thyroid eye disease and treatment options.
Well, the thyroid antibodies are very interesting because for me as an orbital and oculoplastic surgeon, I am primarily focused upon the eyes. So I'm not necessarily, looking at the endocrine status. I'm relying on my colleagues to really help me with that. But from the eye standpoint, I'm looking at a high thyroid antibody, meaning a TRAB or a TSI, in a diagnostic way, which is incredibly helpful because some people, you're not sure whether they actually have thyroid eye disease, when they're very newly diagnosed, and sometimes the eye disease precedes any hormone, alteration. So diagnostically, very important to me. After that, most of my examination becomes more clinical, but a high TRAB or a high TSI really is a big signal for me. Hey, this is someone who might have a very cantankerous disease. And I'll have a discussion with them that maybe we should delay surgery a little bit. Maybe we should go slow and be careful. It doesn't push me one way or another because it doesn't directly influence whether we will do surgery or not do surgery, or do treatment or not do treatment with medical therapy, but it certainly does kind of give a barometer of their overall autoimmune disease state and the likelihood of having issues associated with their eyes that can be quite significant. So I don't monitor it routinely after diagnosis, except if there's some change going on. I usually rely upon my endocrinology colleagues if they're more interested in that, to see if there's some aberration going on with the endocrine status and allow them to order it.
Perfect. Thank you. And that's a kind of a nice segue to discuss kind of treatment for Graves' disease more broadly. And the decision, there's many different treatment options available, medications, radioactive iodine, surgery. And I think this is an area where a lot of patients have difficulty about how do you make this decision, what goes into these considerations, and just having difficulty with those choices. And so I think it'd be a nice chance to talk about these treatment options for Graves' disease in general, and then we can talk more specifics about some of the other things, including thyroid eye disease. So let's start with the medical management side. I'm going to go back to Dr. Mammen for now and talk about, will you speak to a little bit about medical management, what that looks like, and this idea of potential remission and how long you can potentially be on medical treatment for?
Yeah, that's also, I think something patients really do struggle with is, they get told, I see a fair number of patients who've been told, oh, you can't be on medical therapy for long term. You gotta make a decision about definitive therapy. Medical therapy is just a bridge to a definitive treatment. And it's really, I think our thinking about this has really shifted. It's always been the case in Europe that they've used medical therapy long term. I think, radioactive iodine was less available perhaps than here, and maybe also in the US we're more of a like get it done and do something about it rather than just being willing to manage things so I think there's a bit of a culture difference, but there have been some recent papers that have really shown that we can induce remission in more patients by doing longer term medical therapy. And I think that that's really stimulated a lot of interest in the idea that if you're tolerating the medicine, if you have good control, your levels are stable, that you're not having a lot of fluctuations, we're not having to do a lot of checks, it's not really that burdensome to be on medical therapy, you're not having any toxicity, that there's no reason to take people off. You do 5 to 10 years of therapy, about 2/3 of people will then actually be able to come off with a sustained remission, whereas the short-term 12 to 18 months of medical therapy only put about 1/3 of people into a sustained remission, and most people will actually have a recurrence and require additional treatment. The other thing is I have a lot of older adults in my clinic, and there's a lot of people who aren't good candidates for radioactive iodine and aren't, they're not really independent for all of their ADLs. We can't safely treat them. They're older, you really don't want to put them through anesthesia. And, they may be presented with AFib with RVR and were very sick with the initial therapy. They're stable on 2.5 milligrams of methimazole a day. Why would I take them off, right? If everybody's doing well, there's really, I'm often not, I don't feel at all pushed to take people off of medical therapy, in that sense. And so I think, the longer that we do this and the more we think about it carefully, the more we realize that there's really long-term medical therapy is absolutely a viable option for patients. It's hard to predict who's going to have a long-term remission. In fact, none of these studies were very good at telling who is going to have remission and not. Like the smaller your thyroid, the lower the antibody levels. There are some indicators that suggest these people are more likely to have a long-term remission, but it's not a guarantee that you're really in remission and that you're going to go 5 or 10 years without having a problem. It's really hard to tell. So the only people I think who struggle a little bit more with the idea of long-term medical therapy are people who are young, looking at pregnancy, wanting to figure out, what are the risks associated with the different treatments, and that small but measurable risk of birth defects with medical therapy going through pregnancy, I think does give that group of patients pause, and it's something that we do, have to really think about. What's the best strategy in that situation to control those risks and balances. But for all of the medical treatments, the studies that have been done suggest that people are most satisfied if they have control over the decision. And that if you've decided which one you want to do, surgery or radioactive iodine or medical management, that's the best predictor that you are happy with your outcome. And if your doctor's pushing you to do something, then that's where there's friction. So I really try to use a lot of joint decision making, going through the risks and benefits, of each of the different treatment strategies to try and decide on a one-on-one basis what's the right thing for you to do.
That's great, Dr. Mammen. Definitely just that shared decision making and discussing those three options is critical. Dr. Shin, when patients come to you to discuss surgery, how do you think about the risks and benefits for them in deciding who's a great candidate for surgery versus radioactive iodine or long-term antithyroid meds?
So there are obviously pros and cons of both surgery and radioactive iodine ablation. There are real potential complications with surgery, like voice change, postoperative bleeding, and permanent damage to the parathyroid glands. But I do recommend surgery over RAI in certain situations, such as in patients with large thyroid glands where RAI may not completely destroy the thyroid gland. And also in patients with compressive symptoms, would have quicker symptom relief with surgery because it will take some time for RAI to shrink the thyroid gland completely. Also, as previously mentioned, women who are planning to get pregnant, surgery will allow them to plan for pregnancy quicker versus RAI because there is a period of time that you cannot become pregnant. And in patients with active eye disease, which Dr. Douglas will talk about more, are for me not usual good candidates for RAI because it can potentially aggravate their eye symptoms. Patients can also potentially go into remission with antithyroid medications, especially in those who have mild disease. So this is definitely an option before opting for definitive therapy like RAI or surgery. But if they do have damaging side effects from antithyroid medications, then surgery or RAI should be discussed with the surgeon.
Excellent. Yeah. Dr. Lindeman, when patients come to you to talk about surgery, what are some of the things that you want them to understand about surgery, especially those that may have been steered away from considering surgery as an option?
Yeah, thank you very much. I would agree it's such an important consideration. And I think for a long time, particularly in the United States, as Dr. Mammen described, there are sort of these cultural paradigms and influences. For a long time, we sort of thought of surgery as the most risky of the options, or that it's a last resort for therapy. And I wholeheartedly agree with my co-panelists that engaging in shared decision making and identifying those factors that are important to your unique situation is crucial. And I think it's really the responsibility of the physician, the surgeon, in combination, in talking with the patient to figure out the best route to go. I think, like Dr. Shin said, I won't reiterate, but there are some patients for whom surgery really is a better option. I might, in addition to the very comprehensive list that she provided, add patients that have pre-existing nodules. We worry sometimes about giving those folks radioactive iodine because it may not treat the nodules sufficiently. And we may have to have ongoing surveillance of that. We may worry about an increased cancer risk in those patients. I also would say that the data from studies about this are relatively early, but I personally believe there's a bit of signal that radioactive iodine can lead to some small risk of secondary malignancies. And so particularly for young patients, that's another factor that is important to discuss. I think it's important to have that discussion with a multidisciplinary team and engage our nuclear medicine colleagues in that discussion as they tend to be very educated about that. And then the last thing that I would add is there were some questions about, what if I live in a rural area? I hear, people say that the outcomes of thyroid surgery can be dependent upon, how many of this procedure that a surgeon performs. And we do see that relationship in studies that have been done. So the more thyroidectomies a surgeon performs in a year, the more likely for them to have more favorable outcomes. And we see that cutoff sort of at about the 25 procedures per year mark. I really wanted to point out, I think this was included in the links that Kimberly kindly put in the chat. But if you go to the American Association of Endocrine Surgeons website, that is endocrinesurgery.org, at the top in the banner toward the right side of the page, there's a button that says Find a Surgeon. And so you can click on that link, put in your state or town. You can, limit it how you would like. But you can see individuals that are members of our endocrine surgery organization, and these individuals are much more likely than the average person to be a high volume thyroid surgeon. I live in Alabama, where we have lots of people in rural areas. So we offer options for telehealth visits, both before and after surgery. And we work with people, to try to accommodate their unique needs and situation so that they only have to travel around the time of surgery. And the last thing I'll add is if you do decide on surgery and you meet with a surgeon, or even if you haven't decided, if you're ever meeting with a surgeon, you should feel really empowered to directly ask your surgeon about their outcomes. So you want to know, how many thyroidectomies do they do in a year? Can they tell you their personal rate of complications? What is their personal rate of nerve injury or weakness, voice hoarseness? What are their rates of temporary and permanent hypoparathyroidism or low calcium? These are all very appropriate questions, and a surgeon that is comfortable with their outcomes and does this a lot will feel very at ease discussing it with you.
Those are great suggestions. Thank you, Dr. Lindeman. One patient asked, can you talk about life after thyroidectomy? Everyone makes it out to be so seamless, but I found it to be complicated. To our surgeons, what have your patients said? What have you found to be the case? Dr. Shin.
Oh, did you want me to answer that? Okay, sorry about that. So we know that patients who have surgery for Graves' disease often feel better right away, which is wonderful, even by their first postoperative appointment. And those are real, true successes. However, there is some complexity to life after thyroidectomy. Surgery is not, free of any, of all complications. So it is usually not long to get a dose of the levothyroxine adjusted after thyroidectomy. But some patients do feel different because I feel that their thyroid levels have been off for some time, and for some people for years. So they don't really, they tell me for a long time they just don't feel like themselves. And I really believe that when your thyroid function has just been off for so long. For instance, patients who have lost a lot of weight may gain some back after surgery, and unfortunately, that's the one or one side effect that a lot of patients wish that did not come back. But those are realistic expectations after surgery. Temporary hypoparathyroidism, as we talked about, or low calcium after surgery is common, occurring in a meaningful proportion of patients, and can cause symptoms ranging from, mild tingling, but as extreme as muscle cramps, to even more significant issues. Fortunately, most of the time it resolves within weeks to months, but permanent hypoparathyroidism is less common, but also very real, and its frequency varies significantly by surgeon and cento volumes. As Dr. Lindeman already pointed out, surgeons who do a high volume of thyroid surgeries have a very low percentage of permanent hypoparathyroidism, as low as less than 1%, versus a low volume surgeon can have as high as a 30% risk of permanent hypoparathyroidism. And that could be, it's a long, it's a lifelong just taking many, many calcium pills, which is, really unfortunate for some of our patients. Same goes for voice changes after surgery. As surgeons, as we know, temporary voice change is not uncommon after thyroidectomy, but permanent voice change should be quite low with an experienced surgeon. So it's really, important to understand both the risks and the benefits of surgery, and the patients have to make a clear decision based on their individual circumstances and understanding all the risks of surgery.
Right. All great points. Dr. Lindeman, anything else that you would add to that in terms of patients' experience after surgery or specific things they should be asking their surgeons, particular protocols for calcium management after total thyroidectomy for Graves' disease?
Yeah, thank you for that question. This is so, so important. As Dr. Shin alluded to, the low calcium that happens after thyroid surgery in general, whether that's for Graves' disease or if a patient is having their thyroid out due to nodules or a goiter, can be very troubling and can really impact quality of life. I often tell my patients it's a bit of a double whammy in Graves' disease because not only are the parathyroid glands at risk from the operation itself, but you also have a higher risk of bone disease. And what I mean by that is that the thyroid hormone can act in your bones to sort of break them down. And when the thyroid comes out and those levels fall, it's like the bones are crying out for relief. And they say, oh, give me all the calcium back. And the parathyroids are asleep, perhaps, and they're, oh, leave us alone. And so that can result in very low calcium levels. And in the past, we saw reported in studies that many patients, a relatively high rate of patients, would have to come back to the hospital, get IV calcium infusions, things like that. And so many high volume thyroidectomy practices. Now, I will say that this differs. There's a wide range of what occurs across the country, but there are many surgeons that may try to prophylactically give calcium in advance of surgery, help to decrease that bone turnover. And then there are others that will ask everyone with Graves' disease, particularly, to take calcium following surgery, regardless of what their calcium levels are, to try to get ahead of that sort of, the medical word's osteodystrophy, but get ahead of that, bone rebuilding. And some do both. There's a wide range in practices, but I think it's important to be aware that if you've had a friend or family member have their thyroid out, maybe they didn't have Graves' disease, you may have a slightly different experience after surgery related to being asked to take calcium. And it doesn't necessarily mean that you have to take it forever. And so it's important to have a conversation with your surgeon about what their practice is and the success that they have seen with the paradigm or the strategy that they use. The other thing to be aware of is that surgeons will use both calcium in different forms, as well as a super strength form of vitamin D that sounds confusingly like calcium, something called calcitriol, and that just helps the calcium to get absorbed in a better way. So you may see features of all of that, and I try to counsel my patients about that in advance.
Perfect.
Excellent.
Thank you so much for that. Wanted to shift gears a little bit about some of the other modalities now. And one of the ones that we kind of talked about is radioactive iodine. And there's been a lot of questions about how that may impact folks with thyroid eye disease. And so I'm going to head back to Dr. Douglas just to have your comments about folks who have thyroid eye disease and their thoughts about radioactive iodine.
Thanks so much. And really, when we're thinking and when I'm hearing about radioactive iodine and patients coming in and asking me, it's really part of a discussion of a multidisciplinary team. And that team is an endocrinologist. And I ask each of my patients when the discussion of RAI, surgery, medical therapy comes up to really go and speak to an endocrine surgeon and to really delve into the nitty gritty of what each modality kind of looks like. When the decision ultimately, or RAI, is ultimately not mine, but usually I'm putting my finger on the scale and tipping it one way or the other. And I would never tip it towards RAI. I'm always tipping it away from RAI. And the reason why I'm doing that is that it makes my job a lot tougher because even if they don't have any thyroid eye disease, there is a slightly increased risk of developing thyroid eye disease with RAI. And we can usually handle that. Those are usually just mild, transient cases, and we'll follow things very carefully. If a patient already has thyroid eye disease, or especially if they have active thyroid eye disease, we have to be a little more proactive. And that typically means if the decision is to move forward with the RAI, is to give them prophylactic steroids or some other anti-inflammatory modality during that RAI, which will dramatically reduce the worsening of thyroid eye disease. But even in our literature, there is, a shift that RAI and its association with thyroid eye disease, either a new diagnosis or worsening of the disease, is associated, and that probably increases that risk somewhere between 10 to 20%. Now, that's not a be all end all, especially if someone is a poor surgical candidate and has allergies to medication. Those are all other things that have to be taken into account. But as I said, I would be putting my thumb, and drifting away from REI, as opposed to the other modalities, but always talking into it with our team as far as putting the patient first and seeing what really is in the best interest centrally for that patient.
Great, thank you. Another modality that has been come up in the thyroid world is that of radiofrequency ablation or some of these percutaneous ablative technologies. And there's questions about whether or not this can be used for folks with Graves' disease. Dr. Lindeman, and I know this is in your practice, I'm wondering if you could speak on that topic.
Yeah, absolutely. Thank you for the opportunity. So we know that many patients with Graves' disease will also develop thyroid nodules. And you may have seen information that the optimal patient to be treated with radiofrequency ablation or perhaps other types of percutaneous techniques are individuals with solid nodules and a benign disease process, right? So we do a needle biopsy, we confirm it's benign, and nodules ideally between 2 and 4 centimeters in size perhaps are causing some symptoms like compression on the neck or there are cosmetic concerns. But important for me to say, in the setting of Graves' disease, I think Dr. Mammen said very nicely at the beginning, she talked about, the relationship with the antibodies and how that affects the thyroid gland and the feedback to the pituitary. And so it really is a problem of the entirety of the thyroid gland. The whole gland is affected. And so it's really not possible to treat the individual nodules with radiofrequency ablation and make any impact on the hyperthyroidism or the Graves' disease itself. And so this is unfortunately not a therapy that is indicated in the setting of Graves' disease at this point in time. And I'm not sure that we'll ever get there since it is a problem with the entirety of the thyroid.
Great, thanks. And then one other modality people have been asking about is that of these kind of remote access thyroid surgeries, ones where they're not going through the neck, but perhaps going through the mouth or the armpits. Just wondering to see, a lot of folks want to know if this is something that's potentially available for patients with Graves' disease. And Dr. Shin, I'm wondering if you could help answer that for us.
Sure. So as you said, remote access approaches, there's two, there's transoral and transaxillary. Transoral is they make a little incision inside of the lower oral cavity, and transaxillary is obviously underneath the axilla, which allows us to perform thyroidectomy without a visible neck incision. And the cosmetic benefit is real and meaningful for many patients. But I have to say that only a few high volume surgeons perform this procedure in the United States. And if this is of primary importance, then patients should really identify a surgeon who is an expert in these techniques because there are, you're avoiding a scar, but there are obviously other risks that go with these remote access approaches. But what I like to say is that there are some real, strict guidelines when performing these procedures. I would say significant thyroid enlargement can make remote access approaches really technically challenging. And since Graves' disease, as we've all seen, the gland can really be enlarged and very hypervascular. It is important that the risks really outweigh the benefits of performing these techniques. With that being said, though, in experienced hands, outcomes of these can be equivalent to conventional thyroidectomy, and obviously the benefit is cosmetics, which is, in some cultures really important and really important to certain individuals.
Thank you. So there were a lot of questions about thyroid eye disease, and Dr. Douglas, I wanted to start asking you a few of those questions. One came directly for a patient who said that it was someone diagnosed with Graves' disease because of positive antibodies, but for years they had no problems with thyroid levels. They were either euthyroid or even hypothyroid, and nobody could really make the diagnosis of thyroid eye disease. What do you think may have been happening there that affected that diagnosis?
Yeah, so I think that brings up a couple issues. One is that thyroid eye disease, even though it has thyroid in the name, does not overlap entirely with the thyroid. This is really a disease of the bone marrow. It's an autoimmune disease that attacks the thyroid and the tissue around the eyes, and typically two different receptors that tend to overlap. So it's important to remember that we can get thyroid eye disease without any sign of a thyroid abnormality. Fortunately, I get referred that, and in my practice, it's about 10%. It's probably a little higher than it is, nationally, but usually it's about 5%. But that happens quite a bit. And when we talk about antibodies, this is one case where we want to be kind of specific about what antibodies we're talking about. Are we talking about a TRAB antibody? Are we talking about a TPO antibody? Some people will say antibodies, but in here it's really important to begin to distinguish which antibodies and to establish whether they really have a diagnosis of Graves' disease or that's euthyroid or really what's going on. But nonetheless, it does not require active hyperthyroidism, nor does it require any thyroid abnormality. The really things to watch out for often are changes in their appearance and changes in their eye bulging and swelling. And the best way to do that, to judge that, is often just looking at old photographs over the last 6 months to a year. And we'll go on Facebook and we'll go on driver's license and we'll do those things and really begin to establish that, and then dive into CT scans, dive into more clinical, things that are much more suggestive of the disease, such as eyelid abnormalities and such. But really, we're looking for change of appearance, change of the eye appearance in particular, as the first sign and signal to really begin to go down that road.
Excellent. Yeah, that's very well put. And what signs and symptoms should they be monitoring? And as you said, changes in appearance, but is there anything that would signal that something is happening quite rapidly and it may be more of an urgent issue, and they should seek care right away?
Yeah, so thyroid eye disease, once we typically have the diagnosis, which usually happens by the time you're beginning to monitor, but maybe not always. Just because you have bulgy eyes, that doesn't mean that that's a worst case scenario. In fact, some people who are going to lose vision or have double vision that's disabling actually don't have much bulging at all, because the eye just doesn't move forward. It's so tight and so fibrotic that it just expands behind, the muscles expand behind the eye and squeeze the optic nerve. So really, things to watch out for are pain and pressure that don't go away, especially from behind the eye. Any change in vision, especially comparing one eye to the other eye, and how white looks and how red looks, those should be exactly equivalent. And if they're not, you really want to seek a little bit of care. And anyone, if they develop double vision, has to be evaluated. Now, usually urgent means in a period of one, a day or two to a week, as because most of these things can be reversed. But You really can't let that go, and that has to be investigated, typically with some imaging, typically with a much deeper examination process.
Got it. Excellent tips there. And there's such a spectrum of TED's eye disease. What are your recommendations for patients who have mild thyroid eye disease? What do you recommend on a day-to-day basis versus patients who have more significant thyroid eye disease or symptoms of double vision?
Yeah, no, absolutely. And remember, 50% of patients will have mild thyroid eye disease, which is defined as a limited amount of bulging and typically no double vision. And then worsening of that condition has much more bulging, more double vision, and more impact. But what's really interesting is even patients who are characterized as mild versus moderate have the same impact to their daily life. They still don't go out to events. They still have problem with the sunlight. They still can't really see very well when they drive because it becomes very blurry. So baseline management is, before we get into any fancy medications or surgery, the baseline is using artificial tears 4 to 5 times a day, using a little bit of gel or ointment at night, and really lubricating the eyes. This disease attacks the lacrimal gland, which produces the tears. If they're smoking, they absolutely have to stop smoking. That will make the biggest change in smokers almost immediately. And that applies to both vape and any other type of tobacco use. They've all been linked. Selenium is an important supplement, and that can be purchased over the counter, and multivitamin has the same amount. But really, then you get into cold masks or other things that can just kind of help them feel better, especially in the mild cases. But lubrication, lubrication, lubrication will certainly help the vision and will really make an impact.
Got it. Would you like to talk a little bit about the Tepezza as a treatment option? A lot of patients had questions about that.
Sure. So when I present treatment options, I present 3 options to almost every patient, and many of them don't qualify. The first option is to do nothing, but to do all those supportive things we just talked about. And by the time I mention the other 2 options, patients are like, well, I want to do something. But then after I explain the other 2 options, they're like, well, maybe doing nothing isn't so bad. So the second option we talk about is medical therapy. And it used to be 6 years ago or more, that was primarily steroids, et cetera. Now it's become Tepezza. And Tepezza, we did the original research and published the papers on it. And Tepezza has been a remarkable drug, but it has significant upside and it's not right for everyone. When Tepezza first came out, we realized that it blocks a different receptor than the TSH receptor blocks an IGF-1 receptor, which then causes these muscles and the fat to shrink behind the eye and the inflammation to go away. Absolutely amazing, 80%. The downside is, though, that if without proper monitoring, there can be hearing changes in approximately 10 to 15% of patients. Now, with proper monitoring and discontinuation of therapy, we can really eliminate any long-term sequela, but they still exist and requires absolutely to be monitoring. And the medicine, besides being costly, is also an IV and does alter the blood sugar. Usually this can be controlled very well, but especially I hate to use the word, but especially in front of endocrinologists, but pre-diabetics or those patients who have those elevated hemoglobin A1Cs that they ignore, that can really result in some major issues. So really have to watch out and carefully monitor them with the team. And so that's just an intro to Tepezza. An amazing drug, but certainly has to be discussed and put into the right perspective. And then finally, the third option is surgery. Typically, unless it's an acute case, we really losing vision, we think of surgery as something we do in the end where we can reverse the appearance. And essentially what we're doing is, if you have an ice cream cone and you have too much ice cream in a small cone, we're just making a bigger cone and turning your small cone into a waffle cone so that the ice cream can fall back. And that's what the eye does. We're just making more room behind your eye so it can fall back into place. We're not changing the disease. And often we can do most of the surgery in one sitting, but it is certainly, a specialized surgery, and it has to be right for the patient and outlining all the expectations associated with it. Outlining these expectations and these different options, usually it takes me an hour one-on-one with a patient. So, I'm giving you a very brief version, and so patients should expect an adequate discussion from their physician about these options.
Absolutely. Yeah, quite a lot to digest there and to discuss before making that decision. One last question about TED or thyroid eye disease. How likely are patients to have it recur if it resolved with treatment? Patients asked about differences between men and women, or what have you seen?
Yeah, so the baseline recurrence for anyone with thyroid eye disease is somewhere between 5 and 7% lifetime risk. And that's, for everyone. It's a little higher for those with RAI, and it tends to be about 10%. The recurrence coming off at Tepezza, having a little reactivation, is about 20%, and that can usually be treated and then eventually go away. Now, even if you treat with a thyroidectomy, you're like, well, you're removing everything, right? Well, there's still TSHR on the cells behind the eye, the fibroblasts and things they're actually being impacted with this disease. So you're still at risk for a recurrence or for having disease, even if you do a thyroidectomy. Though there are studies which tend to point towards it that likely is a lower relative risk compared to the other modalities.
Excellent. Thank you so much.
Right. And we have a last few set of questions that are going to be directed a little bit toward Dr. Mammen and about how the Graves' disease impacts quality of life and how the role it has on patients in lots of different ways. And a common one that came up was how Graves' disease and mental health interact with each other. And you understand this often doesn't get discussed in clinic visits, but can you discuss a little bit about those neuropsychiatric symptoms and what is oftentimes attributable to Graves' disease?
So I think that this goes back to what we were talking about at the beginning, that, often Graves' disease is a T3 predominant disease. And we know that T3 is actually quite active in the brain. It's actually, there have been some very interesting studies in depression, looking at T3 therapy as an adjunct in people who have resistance to SSRIs in depression, and showing that T3 is as effective as lithium at boosting mood and treating depression. And people are now looking at T3 analogs as an antidepressant agent. And so, there's a lot of excitement around thyroid hormone for its neuropsychiatric properties. And so it shouldn't be surprising that people who have dysregulation of the thyroid hormone levels would have a lot of effects from the long-term exposures and the imbalances that we have from the Graves' disease. And I think this gets back to something Dr. Shin was saying earlier too, that that first experience of going from hyper to normal is very weird for a lot of Graves patients, because your hormones were not right. And some people find that that's actually not great, right? Like T3 is quite, it can be stimulating. Some people feel a little manic from excess T3. And, for some people it's a huge relief to not have that mania and not have that anxiety. And they feel like, oh, this is so much better. But in other people, that T3 stimulation is actually kind of feels more like who they are and how they like to be. And so different patients have very different experiences, I think, with the transition from active disease to more normal states. And then we also have the challenge that sometimes people go from hyper to hypo, and that can be relatively fast, and it can be hard to get the treatment exactly right. And so there's a wide range of how people experience the changes that we go through when we're treating Graves' disease.
Great. Yeah, I think that's really helpful. Another question again about related to daily life is just a practical one, are there foods, are there medications, are there things in daily life that patients with Graves' disease should try to avoid?
Yeah, in general, it's, it's the answer is no, don't make yourself crazy. But there are a couple of things that do definitely impact on the thyroid. I live in Maryland, and so people, I'm not going to I tell my patients I'm not going to tell any patient in Maryland not to eat crabs over the summer, but iodine is a huge source of activation of the thyroid. And so you do have to be a little bit cautious, like in moderation. Please don't have, no crabs every single weekend, right? So, and so you do have to be very careful, I think, about things that market themselves as thyroid supplements, because a lot of those thyroid supplements are actually kelp products with very high iodine content. Those can be very dangerous for people with active Graves' disease, because you give your thyroid a huge load of iodine. It doesn't have the normal regulatory controls, and it just goes to town on that thyroid and it just goes to town on the iodine and makes a ton of thyroid hormone, and it can be very hard to control. And then, the thyroid itself can be considered a food additive, and occasionally you will see products that actually have thyroid hormone, like ground up thyroid in the tablet, that's a thyroid support. So you definitely don't, I tell my patients pretty much don't take anything that's marketed as a thyroid supplement. Dr. Douglas was talking about selenium. The trials on selenium for the thyroid have been less exciting than we hoped. The early trials were more positive than the later trials. I think the data is a little bit stronger for eyes, but there's certainly nothing dangerous about selenium. And so, some people like Brazil nuts, they're going to eat Brazil nuts. Other people are going to, take supplements. Some people can afford that, some people can't afford it. And, I don't think that the data is so strong for it that if it's outside of your budget to take that, you need to, that it makes a huge difference. So I'm not a huge advocate for any of those supplements.
Great. And the last one is related to a topic that it's also popping up in the chat here, is related to weight gain when it comes to either after surgery or methimazole. You can speak a little bit of what's going on and that phenomenon, and also a little bit related to, like, you hear a lot with GLPs and thyroid conditions, and what advice for patients with Graves' disease and GLPs.
Yeah. So, there about 5 or 6 years ago, there was a big study out of England that looked at weight gain after treatment for either with radioactive iodine or with antithyroid drugs. And there's also been studies of after surgery, and Graves patients and hyperthyroid patients in general, regardless of the cause, gain weight more than the weight loss generally that they experienced. Some of that will, over the course of 2 to 3 years, will reequilibrate and come back to normal, but there's definitely kind of a rebound phenomenon after we normalize the thyroid hormone levels. And it's not something that we really fully understand, whether it's sort of I say, our metabolisms are Neanderthals, right? They haven't caught up with the modern food environment, and winter is coming, and it's got, it went through a period of starvation, and now it's going to hang on to absolutely every calorie it can hang on to, right? So there's some of that, I think, that's contributing to the weight rebound, but people definitely will gain, about 10%, 10%. There's about 10% weight gain overall for a good portion of people. So, and most people are low, so that that gets people back to normal for a lot of people. But there's many people do overshoot. There was a lot of concern about whether GLP-1s were causing thyroid cancer, right? Because the preliminary data showed concerns for medullary thyroid cancer in the animal studies. There was no preclinical data for the most common form of thyroid cancer, which is the follicular papillary thyroid cancers, which are the ones that are increased risk for patients with Graves' disease have an increased risk for. In the post-marketing observations, what we saw was an initial, like if you start GLP-1s, there's actually a signal for increased thyroid cancer in the first year after starting GLP-1s, but not 5 years later. And if you think about it, if you start a GLP-1 and you find a cancer within a couple of months, it can't possibly be from the biology of cancer that cancer is related to the GLP-1s. And what it turns out is that it's all surveillance bias, right? Everybody's worried, oh, I need to think about thyroid cancer. I just started a GLP-1. Everybody's getting thyroid ultrasounds. And so there's a huge increase in thyroid cancer detection that's observable in the literature in that first year after people start GLP-1s. But if we look 5 years out from starting GLP-1s, there's no evidence that there's an increased risk of thyroid cancer. And so it's not considered a contraindication to being on a GLP-1 that you have thyroid disease or that you have even that you have active thyroid nodules. It's, or even a history of thyroid cancer. It's only the medullary thyroid cancer that's associated with it. So in general, if people do gain weight and that's something that they've discussed with their primary care doctor that they want to consider, it's certainly reasonable. On the other hand, too, it's, I think if we are more aware of it and we do more counseling about it, I know Dr. Lindeman was talking about, the calcium counseling and like being aware of really knowing what's coming. If you really are aware of it and you're prepared for it, sometimes, people have been really tired, people have lost weight, they've lost muscle. If we go into the treatment with expectations set that we are going to gain the weight, there's going to be some rebound. What are we going to do? How are we going to get your exercise up and make sure you're eating a healthy diet and manage that weight gain? Then we can often ride it out in sort of more traditional measures.
That's great. Yeah, and I think that's quite helpful on topic on a lot of folks' mind. I see Kimberly popping up. How are we doing with time here?
It's about 3 minutes till. Maybe we can tackle a couple of the questions in the chat quickly. And then I've had a couple of people ask offline since we were on the topic of the GLP-1 meds. Is there any chance there's a benefit to Graves or TED with those medications? Because it seems like every other week there's some new study about, they do something fabulous. Do they have any impact on the course of disease with Graves or TED?
Kim, I don't think we have that answer yet. And certainly there is some general idea about anti-inflammatory properties of them, and they're being studied for everything. There are some really interesting new modalities that people are looking at for Graves' disease. I always blank on the FcRn inhibitors, right? So there's actually a new national trial that's being run. These are molecules that target antibodies to try and clear the antibodies out of your blood with much more precision than IVIG, which is a big gun and requires infusions every month. This is a subcutaneous injection, much easier to take. And the idea would be that you could actually clear the antibodies and treat the Graves' disease more directly than any of the modalities that we currently have by trying to target the immune system. And in general, we haven't been using immune therapies in Graves' disease because the side effects of suppressing the immune system, Dr. Douglas was talking about, the steroids and all those things we used to use to try and suppress the immune system to save the eye, and how revolutionary it was when Tepezza came along and we could do it in a more targeted way. This is the same kind of idea. Like, we basically just say, if your thyroid fails, if we need to take out your thyroid or treat it with radioactive iodine, that's less risky than, suppressing your entire immune system and putting you at risk of all the side effects from cyclosporin or methotrexate or anything like that. But if we could get some more targeted therapies that actually clear the TRAb out of your blood, then that might be a nice way to go. So I think that there's some exciting new things on the horizon.
All right, thank you. And before we wrap up, a lightning round to Dr. Douglas. Do you have a favorite brand of eye drops for regular use throughout the day?
Well, not favorite brand, but um, I'll say refresher sustain very quickly. But the key is think of eye drops in three versions. You have the water version, you have the maple syrup version, which is the gel, and then you have the ointment version. You can use them for different times of the day, and they'll blur your vision differently. The water version has to be preservative free. Always preservative free. The preservatives, if you use it, is going to make your eyes red and it's going to make them go crazy. Preservative free 4 to 6 times a day of the water type, the maple syrup type for the, when you really at the end of the day are really struggling, and they're called the gel form, and then ointment at night.
All right. Thank you so much. That's all the time that we have for today. Again, if we didn't get to your question tonight, please reach out to the GDATF. We're toll free at 877-643-3123 or email at info@gdatf.org. So many thanks to the AAES and to all of our panelists, to our moderators, and to all of you for spending some time with us tonight and for coming with your really thoughtful questions. So thank you and have a great evening.